Hopefully you had a nice few laps around the lake with Dr. Wright. You burned off your lunch already. You notice this year we didn't give you the huge cookies that we gave you. I know you miss it, but all right. Welcome back. So the session this afternoon, we're now moving a bit into some very exciting advances in treatment of advanced prostate cancer. There have been a number of very exciting thoughts about how we approach this cancer that we've never done before. And our first speaker for this afternoon is Dr. Paul Lange. I'm not sure it's really on very well. Can you hear me now? Got to get right up next to it. Okay. So our first speaker for this afternoon is Dr. Paul Lange, who is the past chair of the Department of Urology at the University of Washington and is the director of the prostate cancer, of the Institute for Prostate Cancer Research. He's made major contributions in the field of prostate cancer, including early development of the PSA screening test. So there have been thoughts really about how we reevaluate the presence of the prostate itself in the setting of metastatic prostate cancer, thinking that that is still the source of many tumor cells that may be spreading. So Dr. Lange is going to give us an update and discussion about how we think about this.
Thank you, Pete. Good afternoon. It's good to see so many, dare I say, old friends. But since I'm now in that category, I guess I can. And at my age, I begin to realize that life is mostly a series of stories. And so I'm going to tell you a few stories, some history, because I think it's pertinent to this topic. And the first thing I'm going to talk to you about is these two people. This is when I was chief resident, and one of my junior residents is Dr. Clayman, who went on to become chair at UC Irvine, did a lot of other things, and was actually dean of UC Irvine for quite a few years. And when we were in this position, prostate cancer was not very common because PSA hadn't been really discovered then. And when we did find a prostate cancer, which was usually fairly advanced often, but when we could operate on them, we did what we called a perineal prostatectomy. In other words, we went in from below because we thought it was less dangerous than going in through the abdomen, and it was in those days, and we just took out the prostate. We didn't even think about lymph nodes, even though cancer biology and many other cancers, they were already doing that. But these two gentlemen developed the lymphadenectomy, taking out the lymph nodes with the prostate, and so we all started to do that. And initially, we took out these lymph nodes, which in retrospect was kind of silly because they were fairly far away from the prostate, and yet the lymph nodes close to the prostate, because they were a little more technically difficult to do and a little more dangerous, we didn't do. Eventually, however, we began to take out more lymph nodes in the so-called extended pelvic lymph node dissection, and we took out the lymph nodes closer to the prostate. And here is the standard lymph node. Actually, it's not that standard. I was already doing something a little more extreme than usual for reasons I'll tell you in a minute. But then, thanks to some of the work we did, but mostly we work in Europe, we then did a bigger lymph node dissection, taking out more lymph nodes. And we did increase to some extent, about 20%, of the patients who had positive lymph nodes. When we took them out, we cured them. Because in those days, and certainly in the early days, if the lymph nodes were positive, that meant that the disease was metastatic. It had already spread beyond the prostate. And at those days, we thought that you had cancer in the prostate, and then it spread to the lymph nodes, and then to the bone, as you know, or it went to the bone directly, bypassing the lymph nodes. And once it did that, the prostate was not really in the conversation, because the cancer had spread to the bone or to the lymph nodes, and then they kept spreading to more bone and to more lymph nodes, and that was in fact the way we thought of cancer. And we said, well, you don't close the barn door once the animals are already outside because it does no good. You don't take out the prostate when the animals have already escaped. So in those days, we said, oh yes, we need to take out the lymph nodes, and we were so stupid to have not done that before, but the radical retropubic prostatectomy was initially a very dangerous operation, but then it became much more common, much more tolerated, and much safer, and as you know, we moved on from the open radical retropubic or abdominal prostatectomy to the one with the robot. But in those days, if the lymph nodes were positive, we stopped. We stopped because the horse and the animals were already in the barn. We then gave hormones, or took out the testicles in those days. Later on, we gave shots, as you know, and we did androgen deprivation therapy. And in fact, most of the lymph nodes that we took out were patients that the radiation therapists sent to us because they wanted to know if the lymph nodes were positive also, because if the lymph nodes were positive in their environment, they didn't radiate the patient, they put them on hormones also. If the lymph nodes were negative, then they radiated. But then came what I call the Mayo heresy. At the Mayo Clinic, and then very quickly next door at the University of Minnesota where we were, they began to take out the prostate even if the lymph nodes were positive. And then immediately after, or even at the same time, they did hormone therapy. That is, they took out the testicles. Occasionally, the patients forgot about the fact that they were talked about the orchiectomy, and when they woke up, they not only didn't have a prostate, they didn't have any testicles, and some of them got a little upset about that, but they just weren't listening. And after many years of this heresy, and believe me, it was a heresy, most patients, Hopkins being one, they said that's malpractice. That is not indicated. That's terrible. And I can still remember when I was a visiting professor at one of the institutions, Utah, and I took out the lymph nodes and they were positive, and I took out the prostate. And later on, I was supposed to give that a lecture. They almost didn't want me to give the lecture because I had committed such a heretical act. But many years later, when they published a very large series, almost 1,000 patients, and looking in retrospect, they found out that if they did take out the prostate and then did hormone therapy, that the patients did a lot better than if they did the orchiectomy alone. And very quickly after that, well, not so quickly actually, other groups did the same thing. They looked at patients who, for one reason or another, had their prostate out with positive lymph nodes, and for one reason or another didn't have their prostate out, looked at the differences, and they saw that when you took out the prostate, the patients seemed to do better. So what happened then was that more and more people began to take out the prostate. Even the group at Hopkins joined the heretics and began to do that. Funny thing, when that started to happen, the radiotherapists didn't send us the patients anymore. Maybe because if they sent us the patients, they didn't get them back. We took out the prostate. So business being what it is, they suddenly decided that lymph nodes weren't all that important. Later on, they didn't think they were important and gave hormone therapy with more serious cancers and even extended the radiation beyond the prostate. Now, I've got a confession to make because I came from a heritage which involved these papers. Started out with Wyland Letberer, who was a thoracic and general surgeon in the Second World War, became a urologist and trained these gentlemen, some of which have already expired, but were major leaders in urology and were noted for being rather aggressive, macho surgeons. And one of them was my chief, Dr. Fraley. And so I, in fact, sort of developed that and drank that Kool-Aid and did a lot of things in my career, doing more and more aggressive surgery in various places regarding the prostate. In fact, I even had a lecture, would we cure any more patients if we cut people in half? that was a metaphorical statement, although some people began to wonder. And Dr. Clayman, in fact, was drinking that Kool-Aid, although later on he became famous for actually the father of laparoscopic urologic surgery and even the robots. But I must, despite the Kool-Aid I was drinking, point out some caveats to this aggressive approach. One is these were retrospective studies, and some people were saying we were comparing apples and oranges. The patients that only got the orchiectomy may have been older, may have had health issues, and may have more serious disease, so the surgeon said, well, it wouldn't be worth it. And so this comparison was a problem. We tried, in fact, to do a randomized trial. I wrote the protocol, but NIH said it was not ethical and was not possible. But the radiation therapists, I did change that, but it still came out T. Radiation therapists, in fact, did do the randomized trials. And they did, and I'll show you two of them. And in fact, I think that's the most poignant data we have to suggest that this new approach, which I'm going to talk to you about in a minute, might have validity. And what these studies showed when they took patients who didn't have metastasis, but they kind of did. They were very advanced local disease, so many of them did have positive lymph nodes, though the radiotherapists didn't worry about that. And many of them probably had bone metastasis that we didn't yet see. And when they looked at large numbers of patients and they randomized them into patients who had only hormones versus patients who had hormones plus radiation to the local gland, just like taking it out, destroying the gland, they found significant advantages to destroying the local gland. During this time, before and subsequently, tumor biologists, and I'm not going to go over this slide in great detail, began to realize that in addition to having the metastasis beget other metastasis, and they talked to each other or to the lymph nodes, there was also crosstalk with the primary, with the cancer that was still in, particularly if the prostate were still in, because, say, the man came to see you initially with bone metastasis at diagnosis, or positive lymph nodes that didn't have surgery, et cetera, et cetera. And so data began to accumulate even further that, in fact, a prostate that was left in, if you had metastasis, might, in fact, be contributing to the progression of the disease. And then a couple studies came out in retrospect, looking at large databases. And one of them I'm very proud of because it involved Dr. Culp, who was one of our residents, now at UVA, and Dr. Shellhammer, my best friend, who you saw last year, who I operated on actually 15 years ago. And they looked back at the data, and when they found the patients, for one reason or another, who had their prostate taken out when they had metastasis, and compared to the patients who didn't have their prostate out, they found a significant difference. Very quickly after that, the group in Europe did the same study with large databases and basically found the same thing. And then they said, well, maybe this is a good idea. And in fact, other cancers seem to have this kind of tendency, taking out the primary when there was already spread was okay. They mention ovarian, and that's true, but ovarian is a little different. It doesn't metastasize much beyond the abdomen. But randomized trials did show that in kidney cancer, if you take out the primary when there's already spread to the lung or bone, the patients seem to do better. They keep mentioning colon, although I think that data is still very controversial. I'm not too sure I believe it. And they even mention breast. And in fact, here is a recent study in which they looked at the studies in which they took out the tumor in the breast in the woman who had a metastasis. And they did, and again, these were not, most of these were not controlled, but it does kind of give you a suggestion, a small suggestion, that taking out the primary in the face of metastasis might be useful. I hasten to mention, however, that while prostate and breast are almost mentioned in the same breath, they're not exactly the same. Indeed, if you look at the screening studies, mammographies over many years, PSA over many years, you find one difference, which in fact is one of the indictments against screening in breast cancer. And that is that even with all this screening, if you look at the patients who have metastasis when they get diagnosed for whatever reason, it hasn't changed during the era of mammography, whereas in prostate, it has plunged significantly, making some of us believe that if you really look at the data for screening in prostate looks actually a little better than mammography. But the task force doesn't have the guts to give mammography a D rating. It has only a C rating. But there's a good reason for that, because the morbidity from overdiagnosis, i.e. radiation, chemotherapy, is thought not to be as worse as the morbidity for prostate, and there's some justification for that. And so in closing, what's happening is that now more and more people are starting to drink a different Kool-Aid. That is, hey, we can take out the primaries, or we need to test whether we can take out the primary or radiate the primary when the patient has metastasis. And this is one trial, mostly in Europe, called the Stampede Trial, in which part of it has radiation, with or without radiation is one of the arms. Here's another trial, mainly in the Netherlands, in which they've already accrued all the patients, and again, they're doing radiotherapy. And an NIH trial in which they're doing either radiation or surgery and looking at the results. So this is exciting, particularly to a macho type of surgeon, but I hasten to add that this is still very much a hypothesis. If we take out the primary, that is the primary in an asymptomatic patient, are we going to in fact advantage the subsequent course of that patient? I have to mention that if you're symptomatic, if you have pain, if you can't pee, et cetera, that's a different story, and surgery in that case is often indicated. I think it has a very good chance of helping some people, particularly with small amounts of metastasis, but I have to hasten to add that this is still very experimental, and it should ideally be done in clinical trials. Thank you.